All right, can you all believe that we are already on Module 13? It's insane. So we have Module 13 with content, Module 14 with content, and then Module 15 is kind of like review and mainly focusing on writing the paper and finishing that final baseline video. So we are really, truly wrapping up the semester here. Then you should see the rubric for your reflection paper 4, and I have that information posted up too. It's under the assignments. So as far as assignments go, everything should be up. You should have access to stuff. If you want to wrap it up and get things in earlier, I don't care, that's fine by me. So let's get started with Module 13. So I had a couple of articles for you all to read on eCampus. I hope you found them interesting. Typically, I do not go to international articles just for general information. But I decided this week to go ahead and put the couple up that were available because I thought they were useful. I thought they were pertinent, especially the one that came from, I'm looking at here, the Indian Psychiatry Journal, Indian Journal of Psychiatry. And the reason that I put that one up, the Brief Intervention in Substance Use Disorders, was because I really thought that it offered kind of what a textbook might offer, in terms of showing you different case vignettes and really explaining how these brief interventions can be used with individuals with substance use disorders. And even though it's something that was from a different country completely, I think they did a nice job at offering a brief overview of what some of these tools could look like in a counseling setting. So with that, I hope you guys found them interesting and didn't spend too much time on all of them. And really the information on motivational interviewing from SAMHSA could have also been applied to this module as well. So if you wanted to go back and look at all of that at some other point, you could. So let's just kind of get into this. So I've got just a little bit of information here, 7 total content slides on counseling individuals with substance use disorders. And so really to get at the heart of addiction, right? And so looking at the definition of addiction, what really we find out there in the world is that there's not one collective definition that every body or organization or program or theory says, yep, no matter what, this is how we define addiction. They're all similar in certain ways, and I wanted to go ahead and put the APA definition of addiction up here because I thought it was probably the most relevant. So addiction being a complex condition, a brain disease, so we know this now is something that is not a choice. It's a brain disease that's manifested by compulsive substance use despite harmful consequences. And you'll find that there have been some changes in the DSM-5 with substance use disorders and how we classify those. And I cannot remember if it's this class that we wanted you to get the DSM-5 or Med Aspects. It's a good thing to have in general. You'll need it eventually. But of course, there are the certain, there's the criteria that should be met in order to have that type of diagnosis placed on somebody, on a client, under DSM. So when we're thinking about types of substances that individuals use and eventually become addicted to, alcohol, of course, top of the list, marijuana, hallucinogens like LSD, inhalants, anything that's got aerosol in it and some chemicals. Opioid painkillers, prescription medications in general, sedatives, stimulants, tobacco is a huge one. Caffeine used to be on this as well as a type of substance that produces addictive type symptoms within an individual. So if you're looking at this list, it's not all inclusive by any means. Some of these substances are legal. Some of them are illegal. Some of them are legal but are used illegally. So it just depends. And then you have marijuana, which is just the most confusing thing in this country and the world, right? So we have, certain states that say the use of marijuana is not illegal, and the federal government that says it is illegal, and other states saying, well, for medical use it's legal, but other recreational use it's not. So it's just a hodgepodge of CRAP that we have to deal with, and the use of marijuana certainly has come into my work as a counselor with clients in terms of people wanting to continue to use medical marijuana specifically and be protected under federal law, employment law, which doesn't happen. But without doubt, at some point, you will be talking with clients about the use of marijuana. I'm quite certain of that, whether you're a substance use counselor or not. But looking back from a historical perspective about substances, the use of substances has been around since like the dawn of time, essentially. I mean, even if you're looking like way back into biblical times, I mean, we hear and read stories about wine and certain types of alcoholic beverages. Different cultures have used substances in rituals and ceremonies and for celebratory purposes. You know, whether it's, you know, the use of plants as a hallucinogen, or again, producing alcohol of all, from all different things, smoking substances. Not everybody who uses a substance becomes addicted, and within these cultures, use of a substance to get high, essentially, or, you know, get drunk, was perfectly normal, is perfectly normal. There is meaning oftentimes attached to these substances. I mean, if we look at some of the cultures that are out there that use hallucinogenic substances or materials that come from the land, you know, when people are under the influence, oftentimes that's viewed as a spiritual type of awakening, more or less. And so not only is it looked favorably upon, it's almost like a rite of passage depending on what culture you're looking at. So it's not our job, the kind of the take home with the historical perspective, it's not our job to determine what the meaning of using the substance is for somebody else's culture. That's not our job to do. Our job is to understand what it means for somebody within that cultural group to use a substance. And then we also can consider the negative consequences whenever one culture introduces a new substance to another culture. And a prime example of that is what happened with European settlers coming, settlers, I don't like that term, I like conquerors, but the European people coming in and introducing alcohol to Native Americans and not fully educating Native Americans on the purpose of alcohol, the use of it, and now all these centuries later, Native American populations have an extremely high rate of alcoholism, and it continues to be an issue that is dealt with within the Native American population. So, there is a historical context to consider whenever our clients are using substances, and it can go back multiple generations, and it can be very dependent on where somebody lives, where their family came from, and a million other little things that we should be trying to learn about whenever we're conducting a counseling session. So I wanted to just highlight 3 different types of theories that can be useful to pull from when you're working with somebody with a substance use disorder. The first of which being solution focus or brief therapy. And it's a nice therapeutic, it's a nice theory to ascribe by when you're working with somebody with substance use disorders, because the client's the expert. There are a lot of easy techniques. It's relatively brief, it's short term. You're highlighting those little changes. You're establishing tiny little goals for a client to meet that aren't grandiose. The goals that are being developed are realistic and manageable, and they're eliciting change. Even at a small level, it's eliciting change. And for the counselor to not be viewed as the expert can be very meaningful in that counselor-client relationship, because it may be that you're a counselor that's working with individuals who have used substances and you've yourself never been addicted to a substance or are not in recovery. It may be that you are in recovery, but it's not the same drug of choice from the client sitting across, the table or couch or whatever it might be, or at the computer screen from you. And so putting yourself out of that expert role allows your client to have the autonomy that they need to share their experiences with you. So with motivational interviewing, we talked a lot about this whenever you guys were on campus, of course, but it's non-judgmental, non-confrontational, non-adversarial. So, when an individual is coming to counseling for substance use disorders, the kind of being direct and confrontational doesn't always produce the best results. That's a very nice way of saying that if you're confrontational with somebody who's in recovery, you're probably going to get yelled at yourself. So the focus of MI being a lot of change. And if you think about the nice diagram of motivational interviewing and the stages of change, where relapse is built into all of that, right? So it's more or less normalizing relapse as part of the overall recovery process, not being judgmental if it happens or when it happens, and continuing to support the client through their process of change. And it's important to note that there have been some studies that have shown that when clients were in a counseling setting where MI was used versus CBT, that there was a significant difference in better treatment effects over the long term with MI being the theory being utilized. So that means that the long-term effects, so sobriety, obviously, recovery, continued successful recovery, was more likely to happen when the counselor was using MI techniques in theory versus CBT, which tends to be a little bit more confrontational. When we're thinking about narrative therapy, certainly, like, this is, again, taking kind of the multicultural context into it. That's where the roots of narrative therapy really come from. But you as a counselor, you're being respectful. You're not blaming the client for their presenting issues. And it allows both you and the client to explore their worldview, to understand how use of the substance evolved, and to understand how that client's environment played a role in all of it. There's basically like a liberation from all these destructive beliefs. I did this to myself. I'm the problem. If it weren't for me and the choices I made, then none of this would happen. So the client ideally is liberated from that belief system and has eventually develops the view that the problem is the problem, the substance use is the problem, and the client is not the problem. So again, really promoting strengths in our client and encouraging them to see, that a lot of other external influences really make a difference in how somebody uses a substance. So whenever I say, and I really do encourage you guys to do this at some point, when I say the word addict, okay, close your eyes and think addict. What is the thing that you picture? Who do you picture? What comes into your mind? And I think when you see that picture in your mind, that's where you can start to really address values, beliefs, and biases that may come up in a counseling setting when you're working with somebody with a substance use disorder, when you're working with somebody who's addicted. Because whatever that picture is in your mind is what you could subconsciously and unconsciously project onto every client that comes into your office with a substance use disorder, which is not the way that we should be doing the counseling, right? So you have to truly examine your view of substance use. What does it look like to you? What did you grow up learning about substances and drugs and how they were used and how people became addicted? How did your cultural upbringing, your general upbringing, the environment, the community that you lived in, how did all of that play a role in shaping your view of addiction? Even if somebody is in recovery, you may be biased toward one type of addict, okay? So it may be that you think, well, somebody that's addicted to marijuana, well, they certainly don't have as many problems or issues, and their problem is not as bad as somebody that's addicted to opioids, for example. So those are the things that you need to be willing to explore within yourself, right? This is examining our own values and our beliefs and our biases, right? So we need to explore that and examine it within ourselves before we get into the real world of counseling, right? So how do you address your worldview? For one, you recognize where these biases are. 2, you try to understand where they came from. 3, you seek out supervision to try to work through these biases and figure out a way that you can provide effective and competent counseling to anybody with a substance use disorder, regardless of the substance being used and abused. And then you have to start becoming comfortable asking a client about their worldview. How did they come to view substance use? What do they think whenever they picture an addict? Is that in line with what they're seeking treatment for? And one thing to keep in mind within this area is that, and even kind of moving into the treatment versus counseling slide, so if we're thinking about treatment being more of the court-ordered type of therapy that's being provided, somebody is not necessarily coming to counseling because they decided one day that that was enough, that they needed to seek help, they couldn't do it by themselves, and so they came to your office. That's counseling. The client volunteers for the service of counseling. Treatment, we're thinking about treatment facilities, that's more court-ordered, mandated. You may need to report progress or lack thereof. The client may be exhibiting some of those resistant behaviors that we've learned about, and relapse happens. So that's something to be aware of. One of the biggest things that, so when I have been supervising students working in substance use clinics, inpatient, outpatient, one of the biggest issues that they bring to our supervision sessions, in my experience, has been when the client relapses, because there's this idea that somebody's coming to counseling, they're ready to change, they're focused on their recovery, and so the counselor can start feeling a sense of failure when the client relapses. And so we often have to examine that in supervision so that we understand that a client relapsing is not indicative of us failing as a counselor or failing to develop that counselor-client relationship. So relapse happens, whether it's counseling, whether it's treatment. In counseling, it may involve others close to the client. You may be doing some like couples counseling, family counseling. You might be referring out for those services. You may be in either one of these encouraging clients to go and seek out recovery support groups. And this is what I was trying to say before, but I jumped ahead with myself. When you're working with people with disabilities, it's important to understand that that individuals with various disabilities may not be able to be 100% medication free. An individual with chronic pain, an individual with fibromyalgia, an individual that is preparing for surgery that has a history of substance use, those individuals, those are just some examples, may not be able to live in the same way that a lot of the recovery programs encourage, being completely clean, no use of any substances, and any use, even one time, is considered a relapse. So we have to be aware of how those individuals that maybe do need to take medications for one reason or another, and they're taking them and they're legally prescribed and they're taking them in the right way, how those individuals can still seek out support from others in similar situations without feeling like they're failing in the process because they're still taking medication that they need to be taking. And I hope that makes sense. And so that can come up in treatment and in counseling. And within treatment, and if it's a court-mandated treatment facility that you're working in and you're reporting, it's important that you're advocating on behalf of your client. If they're taking a drug test and certain things are coming up and they're legally prescribed those medications and they're using them in the right way, and they're doing great in the recovery process, it may be that you're acting more as an advocate on their behalf to explain to whoever else is uneducated about it, that some individuals still need to take certain medications. And so accessibility, we're thinking about working with individuals with substance use disorders versus individuals with physical disabilities. There's a huge difference in what I mean by the word accessibility, right? So with accessibility and working with people with physical disabilities, it was really like tried and true access, like getting into facilities, right? But if we think about accessibility barriers for individuals with substance use disorders, one that I didn't put on here was stigma, and there can be a lot of limitations in every different aspect of somebody's life because of the stigma associated with having a substance use disorder. But there can be limitations to accessibility of services. Those with a mental health diagnosis who also have substance use disorder diagnosis may be eligible for certain services. Individuals that don't have a mental health diagnosis and are just falling under that umbrella of substance use or addicted to a substance may not qualify for state-funded services. They might not qualify for vocational rehabilitation. And so if they don't, then if we're their counselor and we're working with them and trying to advocate for them, it's a matter of looking up other areas of other service providers, types of service providers that don't have impose those types of limitations. Eligibility for benefits programs can certainly be impacted. When I worked in long-term disability, an individual who is a substance user, somebody that was addicted to a substance, was not eligible for any kind of benefit at all, without question. And if somebody also had a mental health impairment or a mental health diagnosis, the amount of benefit that they could obtain was limited. So if somebody had like a physical disability and was receiving long-term disability benefits, potentially if they just really weren't able to work at any point in their life, they could continue to receive that long-term disability benefit, that monetary benefit for the remainder of their life. With the individuals with mental health impairments, it was a strict 2-year cutoff, no matter what. And so an individual could potentially get those benefits for 2 years, and then after that, no question, no appeal process, money was cut off. And not only that, I found that it was very difficult for people with mental health impairments and substance use disorders to get qualified for long-term disability benefits in the first place. It was almost as light as if the stigma around substance use disorders had proliferated through the entire company, and it was just like if somebody saw that on a file, on a claim, it was like just reject it, the person's a current user and they're not eligible for benefits. And if you think about, our hierarchy of needs and getting basic needs met, if somebody is not able to work at that current time, they're trying to seek out treatment, but they don't have any money coming in, they potentially have broken ties with their support systems, or their support system has broken ties with them as a result of behaviors that came about while the individual was using. A person can very well be kind of left alone in a sea of, of loneliness, if you will. And a lot of times that leads to homelessness and criminal records, people trying to get their needs met in other ways that aren't legal, or relapse. Employment concerns certainly come up. One with relapse and going through the recovery process, and potentially employers, because employers can have policies in place where they don't have to allow somebody to come to work under the influence of a substance. They can have random drug tests and can terminate somebody if they violate a policy around drug use in the work environment, or alcohol use in general too. So relapse can be a legitimate concern. A lot of individuals that have a history of substance use also have criminal records, and that is a whole host of other issues whenever we are looking at states that haven't yet banned that as a question on applications. Individuals may not even get the opportunity to go and sit with somebody, a hiring manager or an potential employer for an interview, because their application's getting booted out because they check a box saying that yes, they have been convicted at some point in their life. And a lot of times individuals don't understand their rights under the ADA. So, that is, I think, a topic to discuss in another point, because really the focus here is counseling individuals with substance use disorders. But part of what our role is as the counselor is to make sure that we're providing education around other things that the client might not know about. So just do know that individuals with a history of substance use disorder are protected under the ADA to different degrees and different ways. Somebody that's currently using would not be protected under the ADA, but somebody that has a history of use, somebody that is in recovery, somebody that is using but wants to go to recovery and is cutting that off. There are protections there, protections from discrimination in the hiring process and employment as well. So that was, again, a little bit fast and furious. I hope that you guys can get a little bit deeper within the the discussion post today on your thoughts around working with individuals with substance use disorders and different therapeutic techniques and different theoretical orientations that can be utilized when you're working with somebody who has experienced addiction. So with that, I'll let you all get to it.